Okay, do you want to share your slides? All right, well, welcome everybody to the N3C community forum. So now we're doing a number of talks that involve COVID data analytics and is along with real world data projects efforts. Next slide, please. So presentation will be recorded, so we should start the recording and use the Q&A button or chat. Next slide, please. And so the enclave, we now have 7.5 million COVID cases, almost 19 million people. So it's a very, very large data set with roughly 3 years of data per patient, and a tremendous number of papers have been produced, tools, and all sorts of interesting results. Next slide, please. So in the next few sessions, we're going to be hosting a talk by Jared Esalone, Temporal Trends in Rural Urban COVID-19 Therapies and Outcomes from Alpha to Omicron. And May 22nd, we're in every other week cadence, oral health domain team updates and enclave publication intent forms, and Chen Liang and Kate Bradwell and Yi Lin, and then protocol pad June 12th by Kate Bradwell. Next slide, please. So, okay, so we are now going to hear about background medical therapy with angiotensin-converting enzyme inhibitors and angiotensin receptor blockers association. So both very common medications, association with mortality amongst individuals hospitalized with and without COVID-19 infection. Actually, very interested to hear about this. There were a lot of speculations early on, and I'm not actually quite sure what became of it all, but I'm sure we'll find out. So Bill Hillgrass, Bill or William, do you go? You're going to start, and then you can introduce.
Yeah, Bill, Dr. Miele, he's going to start us off on slide 1.
Great, okay.
Dr. Miele, you may.
Yeah, I don't see the slides yet.
Share your screen and share the slides and be the one in charge of advancing it.
Okay, great.
That's it.
All right. Thank you for that kind introduction, and thank you all for participating in this webinar. As you can see, this was a large team effort by investigators with multiple IDEA CTRs, supported by multiple NIGMS grant awards. We formed a working group on background medications, and specifically one on ACE and ARBs, as part of a broader consortium that has been operating as a team since the beginning of the pandemic. Next slide, please. So as a way of background, we all know that SARS-CoV-2 infects host cells through its spike protein that binds ACE2, the membrane-bound angiotensin-converting enzyme, on respiratory epithelia, but also on other cell types, which leads to virus internalization. Both beneficial and potentially adverse effects of blockading ACE2 or blockading the angiotensin converting enzyme activity has been posited in COVID-19. Theoretically, blockading ACE2 would disable viral entry into the host cells, but also decrease inflammatory response through maintaining a homeostatic balance between the classical and the counter-regulatory renin-angiotensin-aldosterone system. There is some evidence in a mechanistic study from hospitalized patients that exposure to either angiotensin-converting enzyme inhibitors, and I'm going to start saying ACE, or angiotensin receptor blockers, or ARB exposure was associated with milder infiltration in baseline CT scans, lower CRP and ferritin, higher monocytes, and shorter hospitalization. On the other hand, there is the potential for negative effects because blockading the classical angiotensin, renin-angiotensin system does lead to upregulation of ACE2. So there was at least the theoretical possibility of increasing viral binding and entry by blocking the classical pathway. Next slide. So with that in mind, our main research objective was to determine whether or not background chronic ACE or ARB treatment influences outcomes or mortality of hospitalized COVID-19 test positive patients. The reason why we thought this was important is that this tells us about the importance of the renin-angiotensin system in the biology of COVID-19. And it can tell us about the opportunity or lack thereof of using chronic ACE or ARB treatment prophylactically in high-risk individuals for severe COVID-19, as well as tell us about the opportunity of discontinuing or not background therapy with these agents for patients who are on them during COVID-19. At the beginning of the pandemic, there were calls to discontinue and calls to not discontinue ACE or ARB treatment, and we were trying to solve this question. There were conflicting prior studies with odds ratios for mortality ranging from 0.3 to 8.5. So in either direction. However, a meta-analysis of 52 studies suggests an odds ratio of 0.57 in favor of ACE-ARB treatment for mortality. However, studies that were part of this meta-analysis suffered from inadequate sample size, suboptimal data, and analytical strategy for deconfounding. They did not have medication control groups, no falsification hypothesis control groups, for example, for COVID-negative patients. This is a textbook example of a question that cannot be addressed with a randomized controlled clinical trial. This would not be feasible and probably would not be ethical. And so real world evidence becomes important. A final question was, we're treating ACE and ARB as a single class of medications, but these do work by slightly different mechanisms of action. So is there a class effect, or are the two medication families different? And I'm going to pass the baton to Dr. Hillegas.
So in addition to this pathophysiologic background, there was some clinical motivation for the design of our study. The cohort, we looked at hospitalized patients tested for COVID, both positive and negative test results in the pre-vaccination era, which we defined January 1st, 2020 through April 1st, 2021. The motivation being that obviously COVID mortality was high during that period, so we'd have the most chance to see if there was a signal from RAAS inhibition with ACE and ARB. But we went to extensive effort to define the exposure of interest, which is background medical therapy with ACE, ARB, and with various control agents. And we ended up requiring, after extensive analysis without looking at outcomes of different timeframes, what optimized the concept of a background medication exposure, that the person had to have a medication record at least 90 days before the hospitalization where they had the test, and they had to have documentation of the medication class of interest at least 30 days prior to that hospitalization where they were tested. Jeremy Harper did extensive analyses to try to figure out what time frame gave us the most consistency and yield in establishing whether a patient's on a background medication from sort of a computable electronic health record phenotype, something like non-analysts tend not to think about, that you just kind of know from the record, but you don't. Exclusion was pretty simple. Key missing data. We decided not to impute data, particularly if discharge vital status was unknown. Then, of course, that patient wasn't helpful. Our clinical motivation was we wanted, after defining the concept set of ACE and ARB background medical therapy in which agents fall into those classes, was to also have some active controls that the indications for ACE and ARB have clinical overlap with these other agents, and that included beta blockers, calcium channel blockers, thiazide or thiazide-like diuretics. So then once we identified a patient on background ACE-ARB, we then constructed propensity match groups where they had to be exact matches on the same vector or matrix of ACE-ARB indications and comorbidities, as well as data contributing center and quarter of the pandemic. So we then ended up defining 6 propensity match cohorts, 3 for test positive hospitalized individuals and 3 for test negative hospitalized individuals. The first one was the subject was on ACE-ARB background therapy versus they were not on it. Propensity matched, same matrix of indications and comorbidities, but not on it. On ACE-ARB background therapy versus not on it, but had to be on one of the active control agents to increase, sort of potential overlap of patient similarity. And then the third, what we call the Mealy cohort, after Dr. Mealy, was everybody had to be on the active control agent, either plus ACE-ARB background therapy or not on it. So we have these 6 comparisons, 3 within each strata of test positive and test negative. We haven't seen other publications where anyone's used this, other active control agents as part of the analysis or test negative patients, which is a unique feature of N3C. Outcome was in-hospital death or discharge to hospice. There's been good documentation that including discharge to hospice adds to better assessment of 30-day mortality. And now I'm going to turn it to Dan and Ron.
Yeah, this slide will illustrate what Dr. Halagas just mentioned about our 3 groups. Like when we're looking for the comparison, the effect of ACE-ARB, we will have 3 different comparisons. First is the ACE-ARB versus no ACE-ARB, ACE-ARB, and versus the one only on active control, or the first one with the patient on both ACE-ARB and active control versus people only on active control. And we have 6 comparison model for ACE-ARB. We do the same analysis for the ACE only and ARB only.
And obviously the rationale, just to chime in for a second, for the second and third comparison is that, as you all know, antihypertensive agents are often used in combinations. So we wanted to do as much as we could to isolate the effect of ACE and ARB from what would be a general effect of controlling hypertension. And as you will see, the results show that this strategy was effective.
Yeah, and for comparison model, we will do this two step. One is propensity score matching, and the second one is both matching logistic regression. For the matching one, I use the magic in R bucket and do the exit matching using for all matches. Like Dr. Haragat just mentioned before, demographics, HIV indication step, EGFR, and Johnson commodity index. For both matching logistic regression, we use we look for the probability of being on mortality or discharge to hospice given by being on treatment group, or the demographics adjusted by all the demographics. ACE, ARB indication step, EGFR, Johnson commodity index, and addition of 5 disease like CVA, MI, pulmonary disease, paralysis, and dementia.
Yeah, let's go.
Dr. Hockwell is going to introduce our next one. Oh, by the way, this one uses GML function in R buckets and waited for the distribution of treatment group.
Yeah, moved over here to San's office because it's easier to do the clicking here. So this is just a characteristic of the cohorts in our three for our three main comparisons here. Up at the top, you can see the mortality is pretty high, around 20% or more. But the difference is greater in this first comparison, as you might expect, ACE-ARB versus no ACE-ARB, 21% to 17%. Over here in the other two, the differences are smaller, 21 to 23, 21 to 23, and they're in a different direction. The different direction is due to the greater imbalance in the differing distributions of the covariates. In this first one, we've got ages 68 on average and 59 to 60. But over here in the other two, the ages are very similar in both of these other two comparisons. The gender and race is quite similar. All of the differences, I should say, are very similar. The quarter, just shows you the distribution of the quarters, which is very similar between these two groups, which is a good thing. Because there are some differences, mortality by quarter. Some of the more pronounced differences you see here in this first comparison, ACE-ARB versus non-ACE-ARB, are on these diseases that we used in the exact matching, as Sam said. And so, but before matching, there's quite a difference here between the ACE-ARB and the non-ACE-ARB. Now, if you move over here to the ACE-ARB versus the active control, plus then you see fewer differences. There's these two groups are still somewhat different, but they're more similar than these two were, and the same is true over here. The biggest difference that sort of persists all the way through is diabetes. Quite a difference there, and it does persist over in the others. But in general, this ACE-ARB versus non-ACE-ARB group is the more serious, has the greatest difference between the two arms with regard to severity of illness, background severity. Also, you see it on the Charlson index, the bigger difference here, whereas the differences are fairly much smaller over here for the other two groups. And then see some pretty high comorbidities. These are the additional ones that San used in the model beyond the ones that we matched explicitly on. And you see some differences here in those as well. And once again, the difference is less pronounced for these other two comparisons. What that does here is, if you look at this is the mortality graph pre-matching for ACE-ARB in the first comparison, the second comparison, and the third. This is the one for ACE to no ACE. And as was showing on that slide, there's a mortality difference there. And it's in the smaller difference, but in the opposite direction on the other two. One of the comforting things about it is when we do the matching, post-matching, the mortality differences actually become more similar across three groups. But it's actually nice to know that the matching was robust enough to really adjust for this mortality difference. And now post matching, we see really a switch in the direction of it. We see the same thing over here in our COVID negative group. It's just that all the mortality levels are much lower, only about 5% in that group. But we see the same sort of switch after we did the matching. So overall, as we mentioned before, this is really a high. Our main analysis on the COVID positive group is quite high mortality, the pre and post matching, what's this one say? This is the comparison of the medications up here. Already covered that point. So we have just a more severe, seriously ill group on ACE here to compare to. Turn it back over to San here to go over our balance on the exact matching. Go ahead.
After matching, we used love plot to illustrate how our data balanced, and the exact matching worked well as we expected.
You want to go?
Yeah. Even with the EGFR state, and we got very small residual differences for the 5 addition factors in that for the matching balance. The next one will be the result for COVID test positive.
Oops, I'm sorry. What did I do, Son?
Yeah.
We have on the results for our main results here for the COVID positive group, you can see the odds ratios up there, about 0.85, 0.83, 0.83. The absolute mortality difference is about 3.5 to 4 percentage points to get an odds ratio, in this case of 0.85. And everything here is more or less as you'd expect to see it. The higher these are the I should say these are the parameter estimates after we put them in the post-matching logistic regression model. These are the parameter estimates from that model. This is the sample size, for example, on our ACE-ARB group, 8,311, on the non-ACE 7,024. You see the sample size is over here. Down here, it's the first number before the slash that is the sample size for each of these groups. The odds ratios are basically what we'd expect. The higher age has, of course, higher mortality. Men, of course, have a higher mortality. Nothing new about that. Differences in the quarters, which is good. So it's good that we matched it up. The one sort of an seemingly contradictory thing, or seemingly curious thing, I should say, is the low odds ratio for hypertension. But these are basically, this is a group where everybody pretty much has something. And so fundamentally, there may be a more complicated explanation, but these people are all matched up. And so if you are in the group that is matched and you have, for example, only hypertension, you're probably among the less sick, seriously ill people in this analysis. Our COVID negative test results, won't dwell on those, but rather similar. The odds ratios are more or less of the same order. A little bit lower here, but and this one is statistically significant, but these two are not getting fairly close to 1. The test negative results are a bit mysterious, but we'll go on from there to I think who are we going to next, David?
Yeah, Dr. Chen will continue our analysis for the ACE only, and then only.
So for the subgroup analysis, we then did this to evaluate each class of medication individually. And these are displayed here in pretty much the same manner as the results that you saw just now. So to explain it more explicitly, for patients with background ACE therapy compared to those with neither ACE nor ARB, propensity matched patients, the adjusted odds ratio was 0.86 for the outcome of in-hospital death or discharge to hospice. The confidence interval here for 95th percent is 0.77 to 0.95. For patients with background ACE compared to those with active cardiovascular comparator agents, the Mealy control, the adjusted odds ratio was 0.88. Again, CI, the top range of that was 0.93. For patients with background ACE and CVC compared to those with only CVC, the AOR was 0.86, and again, top number of the CI was 0.98. The adjusted odds ratios for the other factors were comparable in significance to those of the prior combined ACE or ARB analysis that we had seen in the previous slide. Next slide. Similarly, for the ARB group, subgroup analysis for patients with background ARB therapy compared to those with neither ACE nor ARB, propensity matched patients, AOR was 0.85, top range of 95% CI is 0.95. For patients with background ARB therapy compared with active CVC, 0.85, top of the CI is 0.96, and for those with ARB and CVC compared to those with only CVC, AOR is 0.81. And again, the adjusted odds ratios for the other factors are comparable in significance. So consequently, we find that the treatment effect is significant and consistent for both ACE and ARB subgroups. The very large sample size afforded by the N3C registry permitted us to evaluate the ACE and ARB subgroups with more than 80% power to detect a 2% absolute difference in mortality with 20% control mortality risk. A previously published analysis attempting to assess this issue likely had mixed results due to limitations in power. Next slide. So we looked at other factors as it relates to in-hospital mortality for test positive results shown here. And there are a number of other factors other than ACE or ARB therapy as background, and they were significantly and independently associated with increased odds, again, of the outcome of in-hospital death or discharge to hospice. For these multivariate models, we found significance here with age greater than 60 years and more pronounced with older age, with male gender, the earlier quarters of the pandemic, using as reference the winter of 2020, pre-existing congestive heart failure, higher CCI, and a history of dementia. These associations, including the absence of association with African American race, are consistent with what has been described in wider literature on COVID mortality outcomes. History of dementia has an especially high adjusted odds ratio. This likely reflects appropriate family-driven decisions to withhold aggressive organ support care in the elderly with severe COVID disease with severe pre-existing dementia. Next slide. And then looking at these other factors in the test negative patients. And so how many of these factors were also observed in this cohort? They're overall comparable in significance. And there are a couple notable exceptions here. For gender, male gender was only associated with increased mortality risk in the comparison without consideration of active cardiovascular control agents. And that may be due to delayed presentation to care, which is likely not specific to COVID. And we did note the difference in the quarter of the pandemic here. The difference from the test positive one is the third quarter, having opposite association. We suspect this may be due to catch-up volume for low-risk elective procedures, again, in this test negative population. The next slide. So we also did a pre-specified subgroup analysis looking at CHF and diabetes mellitus as specific comorbidities. This here, the comparisons were for the full test positive cohort. The adjusted odds ratio for the 3 sets of comparisons we previously saw. For the cohort of patients who had congestive heart failure and may have had other diseases, and that's what we say with plus here, the adjusted odds ratio for the 3 sets of comparisons were all lower and significant for the ACE-ARB group. And in the cohort of patients who had diabetes and may have had other diseases, again, the adjusted odds ratio was lower for the ACE or ARB groups. In all of these subgroup comparisons, the associations appear significant, with the highest p-value of 0.003 for those who are concerned. And next slide.
So summarizing our results and in comparison to sort of the bigger picture of ACE and ARB therapy, RAAS inhibition, and COVID disease, there was a very interesting study published last month in JAMA, the REMAP-CAP randomized trial. This was a multinational, multi-center study where largely critically ill patients with COVID were randomized to get ACE, ARB, or control. This is not background therapy. This, with our same pathophysiologic rationale of decreasing inflammation, this was evaluating whether these were good COVID-directed therapies to be initiated in hospital. And what you can see is that actually survival was lower in the ACE and ARB group than the control group. The actual primary endpoint of this trial was days of free of needing organ support, and that the posterior credible interval of the Bayesian design of that trial had 95% probability that control therapy was better than ACE and ARB. So this is a different question than what we're addressing. This isn't background therapy, but this is, does ACE and ARB have a role as a COVID-directed therapy in critically ill patients? And the answer from this trial appears to be clearly not. Next slide. There's another type of randomized controlled trial that's a little bit closer to our concept. These are the randomized withdrawal trials. So these are patients on background ACE and ARB therapy when they come to the hospital with COVID disease. And then there's randomization for withdrawal of that in the patients assigned to that treatment group. There's a very nice study done in Brazil, 650 some patients, called the BRACE Corona trial in 2021. And on their primary endpoint of alive and out of the hospital days, there was no difference between staying on ACE/ARB or being withdrawn. Randomization on average occurred on day 2 of the hospitalization. So their primary endpoint, there was no difference, as you can see from these cumulative event curves. However, secondary endpoint length of stay was actually shorter with continuing ACE or ARB than with having it withdrawn, with a mean difference of 1.46 days shorter length of stay with continuing ACE/ARB, and a ratio of length of stay of 1.2 higher for those that had it withdrawn versus that continued it. So here, everybody's on background therapy when they arrive. So there's not this is very underpowered for mortality or, any kind of truly sort of meaningful endpoint. But we've noticed in other studies that length of stay tends to be a pretty good sort of surrogate for endpoint with more power as a surrogate endpoint for COVID outcomes when sample size is small. Next slide. So as we've mentioned, there have been a boatload of observational studies of RAAS inhibition. I wanted to just mention 2 that are particularly nice and good. They're both from the veteran system, so they had pretty, good sample sizes. The first one's a really nice study. All veteran comers that were diagnosed with COVID, and then of that group, the ones on ACE were propensity matched for treatment with ACE with a control group, and then they were followed for all-cause mortality. And in this propensity matched analysis, being on ACE or ARB background therapy had a hazard ratio for all-cause mortality of 0.87, which was statistically significant and eerily similar to our adjusted odds ratios. So this is all comers, not just hospitalized patients. In another veteran study where they looked at 9,500 hospitalized patients with C19, and then those on ACE inhibitor, they propensity matched them for treatment with ACE and looked at mortality at 60 days. And this doesn't quite answer the question. Those that continued ACE through the hospitalization had an adjusted odds ratio for 60-day mortality of 0.6, which was significant. And those that had ACE discontinued in the hospitalization, it was 1.4. But this is obviously, confounded. Whenever you have a patient becoming critically ill and they get acute kidney injury or hypotension, you're going to stop their antihypertensives, including ACE. So I think this is just a marker, discontinuation of ACE. Unlike the randomized withdrawal trials, this doesn't really help us. Then there have been numerous observational studies that really, many of them have the many flaws of almost, typical of observational studies, but they get sort of homogenized in a large meta-analysis and meta-regression that has this adjusted odds ratio of death of 0.57, which almost, as a clinician, what I would say is that lacks like face value validity. I mean, you can hardly identify any factor that's that protective, against COVID death in hospitalized patients, except for a very young age. And they also showed, but I think this is a problem that the underlying studies are of such questionable quality that it's not clear that odds ratio adjusts for those baseline differences. So I think we have to take this as information, but sort of rather limited value. Next slide. So what are the relative strengths and limitations of what N3C provides here in our analysis? So inherently, this is an observational question. It's hard to conceive of an ethical and practical RCT for this, as Dr. Milay mentioned. With N3C, we just had incredible available data. We could really kill it with sample size and do this exact matching on a matrix, a vector of multiple factors for each patient. We had detailed IPD with up to 2 years of look back to ascertain the exposures to background medications. Very few of these studies, except the VA studies, had this anything close to this sample size or detailed IPD look back. Analysis, again, a lot of this is a function of our sample size that we were able to do this. We have this, complex vector of exact matching on indications for RAAS therapy, as well as demographic, data contributing center, comorbidities, to really try to deconfound this comparison. We had these active cardiovascular medication control groups that were still quite sizable, given the amount of data we had to start with. Our subgroup results are very consistent and adequately powered. We have this contemporaneous hospitalized test negative control group that acts as a falsification hypothesis, and particularly when you add in the active control medications, we don't see a significant effective ACE-ARB background therapy in those groups, providing some further assurance that our analytic strategy is deconfounded. This association, and the association we're observing has some, although observational, has some credence. So limitations. Despite all of this, the E-value of our study for the point estimate is 1.43. Where everybody's familiar with p-values, the strength of statistical significance, but the E-value is the sort of the strength of the observational evidence. And what the E-value is that what is the minimal association that a confounder or set of confounders would have to have with both the exposure of interest, ACE-ARB, and the outcome of interest in hospital mortality, discharge to hospice? What joint association would it have to have with both of those to explain away the observed odds ratio in our case? And then the confidence interval E-value is what association would a confounder, an omitted confounder, or set of omitted residual confounders have to have for our association to move to non-significance, and that's 1.27. And this is conditional on the the factors that we have considered in the analysis. So those are built into this. And in the e-value literature, 1.43 is considered sort of moderately robust, although obviously you could game that by how little thinking do you do about what other confounders may still be out there that you would omit it. And our kind of diverse group with diverse backgrounds, including several clinicians, I mean, we really thought quite hard about making sure like everything under the sun that we could think of was, you know, built into our analysis as a matching factor or as a post-matching logistic adjustment factor like stroke, MI, pulmonary disease, dementia. Again, this is a pre-vaccine cohort with a high baseline mortality. Whether this would be true in our post-vaccination era, and where, you know, a large proportion of the population has had COVID and may have natural immunity, remains to be determined. So back to Lucio.
So what have we learned so far? With the caveats that Dr. Hillegas just told us about, in high-risk patients, background chronic exposure with ACE or ARB is associated with a 13 to 70% lower adjusted risk of mortality among hospitalized patients being treated for hypertension. These results are consistent with some of the previous observational studies and meta-analysis, but also address a number of methodological limitations in prior studies. This supports further investigation of both the basic science and clinical investigations of COVID-19 effects on the renin-angiotensin system. It tells us that it's most likely safe to not discontinue routine chronic background ACE-ARB treatment and hospitalization for COVID-19, and that perhaps considering prophylactic, not treatment, prophylactic use of ACE or ARB in high-risk individuals for severe COVID-19 may be a reasonable choice. In the N3C cohort, exposure with chronic ACE or ARB background therapy is associated with favorable outcomes, in contrast with the adverse outcomes of using these agents for acute treatment of COVID. And this illustrates the difference between chronic background exposure for a different indication and using a particular class of drug as a therapeutic agent in a patient who is naive to those drugs. And I would like to stop here. And on behalf of our whole team, thank you for your attention.
Thank you. Really very interesting talk and an incredible amount of work. We have questions. So I have one. So what do you know about whether anybody has tried to do this sort of analysis for response to other viral illnesses, say flu? So if you did the same thing and you asked, is ACE ARB chronic therapy, you know, positive in terms of high risk for flu mortality? Has anybody done anything like this?
This is Bill. Not that I'm aware of, but interestingly, our group has such a proposal to look at it with influenza virus that we're beginning to work on.
Okay, right. I mean, because obviously it could be it could be that there is some sort of background effect that reduces impact of viral infection in general. It could be an artifact, or it could be COVID-19 specific. So that's interesting.
Yeah, so I don't want to say too much because it's not my project, but you know, the other question is past post-acute sequelae of COVID, is that COVID specific, or we see that like post-ICU syndrome and people like bad sick from anything?
Right, right.
And, do you also see that like essentially long COVID with other viral infections?
Exactly. Yeah, no, and that's obviously a huge issue. Another thought came to me. So take other data groups that aggregate data, and Trinetics is actually a good example. They've got a big data warehouse, and not as and if you thought about presumably it should be possible to replicate most or all of this analysis in Trinetics, and given the extremely complicated nature of the sort of correlations and the propensity matching, really an independent data set would be really interesting. Have you thought about that?
Independent and large, both of which
Large.
Trinetics is. Because a lot that helped us here is the fact that we have a very large sample size. Yeah, then it's a fantastic idea.
So we are
Very
actually,
worthwhile pursuing.
yeah, we are actually doing some work with UT Galveston in terms of using Trinetics in training, people to do investigative studies. So that could be quite interesting. Also the flu, but of course, Trinetics would, in any event, yeah, no, that would be, that's because this seems like, among other things, an incredibly interesting use case for a complex analysis. I mean, another thing that I'd suggested with Trinetics folks, and I'm not sure if you guys have done, you probably have, because you've been really comprehensive about this, is sort of a red team, blue team approach, where if you say, okay, you've got a group of people who want to find that ACE-ARB is bad, right? And then you've got sort of like a debate team, and then you've got the guys who want to find that it's good, and you see how far each group can get. I mean, because propensity matching, when you have so many variables, is I mean, and you guys have done an incredible job of really dissecting this. But if you had a team that really wanted it to come out the other way, it'd be interesting to see what you got.
Along those lines, one thing that could be done is actually to do both analyses with essentially the same data set. Say with the N3C data, if we've got this one, but can we do I don't know if we see it at all out there. If it's happening, the question would be prospectively, are we seeing ACE-ARB used? That would be an interesting analysis if it's used as a therapy at all. If we could detect that within the N3C data, do we see the effects that have been seen in those in particular the trial reported in JAMA, and yet still see our background effect?
Right, and that is interesting that that trial got such similar results. That is so cool. Are there any questions? I don't see any. I want to make sure I'm not missing something.
You had some great ones though. So
okay, no, this is great. This is really interesting, and I do think it's in addition to the being sort of an interesting scientific result from a methodological point of view, and the E values are sort of interesting. I'm really not an expert in this stuff, but this is clearly one of the issues with real world data analyses, is getting people getting a greater understanding of what one actually what criteria makes sense for actually believing that the result is generalizable, as opposed to you believe that the result occurred in that population with the analysis you did, but does that actually mean that that there's a causative effect. So, cool. All right. Well, thank you. Really interesting talk, and see everybody in a couple of weeks. Thanks for coming.
Thank you.
Thank
Thanks for
you.
presenting. Take care. Bye-bye.